visiting resident at the Oncology Center, Mansoura University. She has two small cases to discuss today. Noreen, are you ready?
Yes. Hello, everybody. I'm going to show the screen.
تمام شايفين.
Hello, everybody. I am Noreen. I'm medical oncology resident doctor. It's my pleasure to be here and to present these interesting cases with you. I will start with the first case. Our lady is 37-year-old, presented with cough. She is a non-smoker, but she has history of bronchial asthma. She has a free surgical and family history with BS of 1. Post-contrast CT chest was done on October 2021 and showed left infrahilar mass about 9 by 8 by 6 centimeter with multiple area of cystic degeneration and two small lymph nodes. The largest was about 12 by 7 millimeter. So it is picture of carcinoid tumor, mostly atypical type for bronchoscopy. Bronchoscopy and biopsy were done. The lavage fluid showed a little cellularity and excess blood, and no atypical cell were detected. So the patient was advised to follow up, and non-contrast CT chest follow-up showed stationary course of the lung mass. However, the patient underwent surgical excision on July 2025 after 4 years of presentation. And post-operative pathology show a well-differentiated neuroendocrine grade 2 atypical carcinoid. Ki-67 was 4%, so it is a pathological T4 NX neuroendocrine tumor. Post-operative post-contrast CT chest after 3 months was free. And now for discussion. Is there any role for adjuvant treatment for this case, or any role for adjuvant radiotherapy?
So, this is a wonderful question. It just happened that I presented a case scenario at Matos, which is the Masters of Oncology. And if you like, I can share actually the presentation. It's very useful, but I can share it after our discussion, of course. The problem with atypical carcinoid is that we don't really have, consensus about adjuvant therapy in typical or atypical carcinoid, if it's a node positive or even if it's a large tumor. You mentioned also that the surgical margins were negative, which is really good, and it looks like a patient already got the bulk of the disease out, and seems like 3 months afterwards also they don't have evidence of disease. And in my presentation, actually, I put all the NCCN because we did challenge the NCCN in that topic about adjuvant therapies. In there, they put like a category there that you can consider for those higher stages to give adjuvant, platinum, like it's a small cell lung cancer. But, typically if you ask, it's very, very controversial. And if I'm allowed, like for those few minutes, I can also present like a similar case
Yes,
presentation for that.
Yes, for sure. You can go ahead and share it now. So
But I
because
want
it
to
will
see
be
the rest of the team if they agree
Yeah.
on that. But yeah, if you want, I can share mine as
Sure,
well.
yes. Yes,
Yani, from the natural course of the case, natural course of the disease, we can see that it's a slowly growing tumor, or more or less low grade malignancy, despite the large tumor size. Over years it didn't change in size, and the mitotic activity in the histopathology was very low, so it goes with well differentiated low grade malignancy, what we call atypical carcinoid, and it was not associated with any secretory manifestations or hormonal secretion. So based on this data, the role of systemic therapy is not there.
Right. Yeah, thank you so
Yes,
much.
I agree. I just wish that the surgeon would have done like mediastinal staging. It would be better, and we would be like more confident to follow the patient up. Otherwise, yes, maybe follow-up is the best option for her.
Yes.
Right. Yeah, anybody else? I'm gonna present something maybe a little bit similar, that I had a 65-year-old gentleman that I've seen myself with excellent performance status and had right lower lobe mass that was also, resected with lobectomy to be T2N2 at that time. So at that time it was mediastinal, like they did like lymph node resection, and you're absolutely right. Of course, you want to have the appropriate pathologic staging. So T2 and 2M0, and at that time I was against adjuvant therapy. We had also the PET scan done, but unfortunately, like that also was discussed in tumor board, and basically people were very concerned about N2. Patient was also very, very anxious. So patient was given the 4 cycles of cis etoposide, and I'll tell you the reason behind that as well. It was initiated. I did actually, work, and we submitted to NCCN about the survival benefit of adjuvant therapy, adjuvant chemotherapy in those pulmonary carcinoids. It was presented in 2021, and with so many studies that were gone through, that basically it doesn't really make a difference. It's there are like 80 abstracts we looked at, and we evaluated the in-depth all the statistical analysis of those 4 out of 11, and based on all the current literature, it was no definitive evidence of having adjuvant therapy for those typical or atypical carcinoids. The NCCN panel continues until this. We accessed this until 2025, and they still put here something called like a consideration of adjuvant platinum etoposide, sort of like with or without radiation in patients with stage 3A intermediate, which is atypical carcinoid. Having said that, if you ask exactly like our tumor board, mentioned, that it's not something based on the literature too much like supported. So this same patient that I'm talking about, just really little bit after less than a year, presented with no carcinoid symptoms, but found to have metastatic disease. So, it wasn't that that adjuvant therapy good or anything. So a patient was treated at that time. It was with endocrine. He received the LA, long-acting somatostatin, had that as like a palliative therapy. So, so basically, those patients, just the conclusion cannot be drawn, to look into that. And then after that, it's just like so many other trials, basically with metastatic disease, that you can offer temozolomide or somatostatin and things like that. So I'm just gonna end the show there. And there's also lutetium dotate, so many other options in the metastatic cabozantinib, and so these were the treatment on progression. So I would recommend that the patient be treated if you find evidence of progression later.
Yes.
Could be temozolomide, capecitabine, any of those combinations. So thank you. Stop sharing.
As we all know that the mechanism of chemotherapy will act on rapidly proliferating cells. And once the Ki-67 as a proliferation marker is low, we do not anticipate the response in the adjuvant setting. But in the metastatic setting, this is a different issue. Chemotherapy can work in metastatic setting rather than in the adjuvant setting. Yes, I agree. Okay, go on.
Okay, thank you so much.
Any other
Next
questions for this case?
Again, the radiation therapy also, being well differentiated neuroendocrine tumor with low mitotic index, and there is no residual and there is no bulk. Even if there is residual, we follow it up. There is no rule for adjuvant radiotherapy in atypical carcinoid as well.
I mean, except of course if the patient is symptomatic or if there's
Yes, if there is residual, big residual or symptomatic,
exactly.
yes, it's okay.
Yeah.
But for such a case we are discussing, there is no rule for adjuvant radiotherapy.
What if there was asymptomatic residual? I mean, like lesion, but no symptoms whatsoever.
Even
Would you give
you
systemic
can follow it
treatment
up.
or follow up?
Yeah, I agree. You can follow up and then see how it is. I would also recommend something else. If you find another lesion later along the road, I would recommend, and if it's accessible, like in the liver or something like that, to rebiopsy and to
Yes.
sort of like send also molecular profiling and find out what that is. Because I've seen also cases where you have mixed pathology between
Yes.
carcinoid and adenocarcinoma or squamous or something else.
Yes.
Mhm. But there is no transformation from small cell to non-small cell. The other way
No.
around happens, صح?
Well, it's very rare because also, as you see, the patient is a never smoker. It's like well differentiated. Um, again, you never know. There are other reasons that we want to make sure to look at because of pollution, because of other, reasons people can have adenocarcinoma or other reasons. So I would follow the patient every 3 months, exactly like you're doing, and just see how the clinical picture and the imaging studies show.
Okay,
Dr.
thank
Manar,
you.
you can see that the patient was يعني asthmatic for long period, and this is the usual presentation of neuroendocrine tumors. Usually they present with non-specific symptoms with the chest, and they like irritable bowel syndrome if we are dealing with carcinoma of the GIT. So the main issue here is to remove the lesion, as long as it is not associated with the hormonal secretion. If there was secretory, octreotide could have a role, but in such particular patient, systemic therapy has no role, as Dr. Nagla mentioned, and even the radiotherapy has no role as long as the patient is asymptomatic and the post-operative CT scan is free.
Yeah, that's amazing. Okay, thank you.
Okay.
Noreen, can you start the second case?
Okay, thank you so much. Our second case. Our gentleman is 58 years old, presented with cough for 1 month. He is a smoker and has a history of COPD for 12 years. He has free surgical and family history with PS of 1. CT chest was done and showed solitary solid pulmonary dules, about 2 cm. Lung grade 3. So now we can ask, what is lung grade and how to manage pulmonary dules? Dr. Manar, here you are.
Okay. Next slide, please. So LURADS is a similar to BIRADS that is present in breast cancer. It's a way for standard reporting of the results of the low-dose CTs used in screening for lung cancer. Next slide, please. So we have like from 0, the thing that we don't have to worry about, to 4B. This is a very suspicious lesion, which has an estimated malignancy risk of more than 15%. Next slide, please. So when we find a solitary pulmonary nodule in a low-dose CT in a patient undergoing screening, we have to determine 4 factors to decide what is the next step to do for this patient. The first thing is to calculate the odds of malignancy. We get it from tables. I will talk about just in a second. The second thing is you should have the patient age, smoking history, and the diameter of the nodule. Okay, so all these likelihood ratios يعني بنضربهم في بعض وبعد كده بنحولها بقى ل probability of cancer. مننا بنقسم الأودز اوف كانسر على 1 زائد الأودز اوف كانسر. يعني زي مثلا بيشنت لو عنده 55 سنة وبيشرب 30 سيجارة في اليوم وعنده 2.5 سنتيمتر نوديول، كده هنضرب بقى 1.7 في 7/10 في 1.5 في 2، هتطلع الريسك بتاعه بعد ما يتحول the probability of cancer risk بتحول to 78%. So this is justified we should do like a biopsy or a PET CT and further investigations for the patient. Next slide, please, Nuri. So this is what I was talking about, the likelihood ratio that depends on the size. So our patient, for instance, the tumor size is from 2 to 3 centimeters. So we have likelihood ratio of 3.6. The patient Smoking history, he was a smoker. So this is a carries likelihood ratio of 2.27. Next slide, please, Noreen. So I have calculated the patient risk and it turned out to be moderate cancer risk. Next. So in moderate to high risk patients who have solitary nodule more than 8 millimeters, we should undergo FDG PET-CT biopsy or resection. Next.
Okay,
What to
back
do
to our
with
patient.
Mm.
Yes. He lost a follow-up and CT chest with contrast after 3 months, showed irregular mass at right upper lung loop, measure 3 by 4.2 centimeter, and enlarged hilar lymph node. Metastatic workup was free. So according to NM9's edition, patient stage is 2B. Okay, and CT-guided biopsy was done, and histopathological examination show a well-differentiated adenocarcinoma with lipidic pattern and lymphovascular emboli. Immunohistochemistry was positive for CK7, TTF1, and negative for CK20. So, what is the best choice for this case? Surgery or neoadjuvant treatment? Dr. Manar, again, the floor is yours.
Okay, I'll just summarize quickly. So we have multiple approaches. Not one size fits every patient. You could go for upfront surgery and followed by adjuvant 4 cycles chemotherapy plus or minus immunotherapy, like the Empower 010 trial that tested 1 year of atezo, or Pearl's Keynote 091 that tested 1 year of adjuvant pembrolizumab. You could go for neoadjuvant immunotherapy plus chemotherapy, like the Checkmate 816 protocol that produced the event-free survival of 40 months versus 17 months in the standard arm. Or you could go for the perioperative approach and use the IO in the neoadjuvant and adjuvant setting. You have multiple agents you can give, like pembrolizumab according to Keynote 671, or durvalumab according to the EGAN trial, toripalimab according to NewTorch, or nivolumab according to Checkmate 7070. Okay, next to Noor. So this is the NCCN guideline. I just know today that we have a newer version of February 2026.
Yes.
Yeah, they change very quickly, but this part didn't change, thank God. Our patient was the stage 2B. Actually, every option is available. You could do upfront surgery. You could, if he's inoperable or high risk, you could go for radiotherapy as definitive approach, followed by adjuvant, or as a neoadjuvant approach, chemo plus or minus radiotherapy, followed by surgery, followed by consideration of adjuvant systemic therapy. Next to Noor. Or you could go for definitive concurrent chemoradiotherapy followed by durvalumab if there was no EGFR exon 19 mutation, or osimertinib if there was EGFR exon 19 mutation. Yes, I just wanted to mention the Pacific trial. It was a crucial trial that gave hope to those patients with stage 3 disease with the using of consolidation durvalumab after concurrent chemoradiotherapy produced a magnificent overall survival of 47 versus 29 months. Next. And it also opened a way to think about can we give durvalumab after sequential chemoradiotherapy? Yes, we can, but it will be like less beneficial. And what is the ideal duration of consolidation durvalumab? Can we incorporate durvalumab concurrent with radiotherapy at the same time? And can we give durvalumab in patients with EGFR mutant non-small cell lung cancer? Next. Well, but we shouldn't, because we have like now osimertinib after concurrent chemoradiotherapy following the ADORA and the LAURA trial, producing a very, very good survival benefit for those patients. Next, please. So I want to know what Professor Salah and Professor Naglaa, what do you prefer? Do you prefer to give just a neoadjuvant, or do you prefer the perioperative approach?
Dr. Naglaa?
Okay, so you brought up very, very important points. First, I would prefer at this point, if you have the prospect trial, if there's a clinical trial, it will be very important to enroll patients in clinical trial. That prospect trial is a SWOG study to randomize patients to either upfront surgery followed by adjuvant, or to have neoadjuvant followed by sort of like the surgical resection followed by adjuvant therapy. That's number one. Number two, it's very critical that we do the multidisciplinary tumor board discussion, because basically me as a medical oncologist, it's very difficult to dictate, is this patient going to be a surgical candidate or not a surgical candidate, without the presence of my thoracic surgeon, and of course radiation oncologists, like the whole team, to discuss if this patient in specific is a candidate for surgery, or it's better to do neoadjuvant. Okay, so what is the tricky situation? Tricky situation is, sometimes patients have a right-sided lesion. If pneumonectomy happens on the right side, it's always accompanied by poor survival and poor outcome. If the patient has a pulmonary function test that's not optimal, if the lesion is close to, sort of like major blood vessels or the airway, that, patient is going to have significant morbidities after the surgery. Of course, neoadjuvant is better. The prospect study is going to tell us, because sometimes if you see, for example, pancreatic cancer and other types of cancer that we learned from, it tests the biology. If I do the neoadjuvant, then they do that. Sometimes patients are very, have a very aggressive disease that if I do surgery, they like metastatize quickly. So it's better to do the neoadjuvant upfront. And so at this point, because we still are early in this area, it's better to have a patient-by-patient scenario discussed in the multidisciplinary tumor board. And, of course, neoadjuvant is a good technique. What I know, because I'm in Egypt, actually, I'm coming to Egypt like in the next maybe 2.5 weeks. So I know that there is, a burden about immunotherapy. So that's why I want to know, because if I don't want to compromise the patient's care if I don't have access to immunotherapy, for example. So it's better to know ahead of time. That's number one. Number three. Number three is patients cannot have immunotherapy with radiation. It's not because of safety, but because in several studies, even maybe you didn't mention, but I am also part of, like, there's another study that enrolled patients with SBRT. If I'm giving atezo or I'm giving IO with the radiation, they don't have benefit of survival. So that happens between LU005, for example, for small cell, compared to, giving the immunotherapy after the radiation. So anytime you do the like durvalumab, even for stage 3, you want to do the immunotherapy, do it after the concomitant chemoradiation and not sequential, because the sequential takes away the benefit of the immunotherapy. So that's one point. Last but not least is basically you always, and this have to be present in Egypt. We have دلوقتي المختبر عندهم already molecular profiling. It's more and more present locally. And we have to do molecular profiling for those patients, because if I have an EGFR exon 19, 21, the common mutations, if I have AL-CROSS, all of those patients will benefit better if I give targeted therapy, even in the adjuvant setting. طبعا in neoadjuvant we're still early. We can't say, we don't have studies for this. It's very important to know, because I don't want to give immunotherapy for someone who's EGFR common mutation as adjuvant. It's better to do targeted therapy. Last, we have to have our own database for our patients, because our patient population is different and unique from Western population, Chinese population, Asian population, you name it. We always have our own pattern, maybe our own pollution, our own risk factors. So we always have to rely on having our database, hopefully in the future.
Okay. Can I share something?
Sure.
Okay. As we mentioned, the patient is chronic obstructive pulmonary disease, long-standing. His performance status, despite that, is still performance status 1. as Dr. Nakla mentioned, we have to do the genetic profiling. يعني we have to have EGFR testing, we have to do ALK testing, we have to do BDL1 testing. And based on these molecular targeting results and the performance status of the patient and the expertise of the thoracic surgeon, we can decide. يعني we can decide to go for as Dr. Nagla mentioned, neoadjuvant treatment, whether with chemotherapy with immunotherapy or chemotherapy alone, versus frontline surgery and then give chemotherapy in the adjuvant setting, or chemotherapy plus immunotherapy and immunotherapy again as in the adjuvant setting, as you mentioned in some studies before. So the consensus or the standard is to have the molecular profiling of the patient. If the patient is EGFR and ALK and BDL1, if it is BDL1 positive, you can go for neoadjuvant chemo plus immuno. If the mutation is present, you can go for frontline surgery and then give the chemotherapy in the adjuvant setting, not the other way around. Okay. This is my interpretation of such a case. يعني the literature also recommends this. يعني you have to have the molecular profiling of the patient once you have a pathology, and the pathology is adenocarcinoma. So
Yes.
you have to do the profiling as Dr. Anakla mentioned. Okay, Mai.
Yes.
Yes.
Can I ask you a question? So is the bronchial asthma, as it has like an immune element, is it a contraindication for immunotherapy? Or we shouldn't put it into consideration?
No.
It's not a contraindication, but you also mentioned something that basically there are some specific immune toxicities that, for example, we treat patients with rheumatoid arthritis, with other like autoimmune disease. So I do treat those patients, but at the same time, I have to take into consideration so many other things. So some patients like rheumatoid arthritis or others are on methotrexate, are on immunosuppressives, things like that. Those patients, sometimes if they are on all those treatments and they have flare-ups and they're having a quality of life issue, especially that we do the immunotherapy for long period of time, we have to always measure the risks and the benefits and see what the patient is tolerating. I'm not going to compromise patients' quality of life by introducing any of the treatments that would not be tolerated. So that's an important point, but we always have to take it one patient, patient by patient.
Okay, thank you.
Yeah.
So from all the, I'm sorry, Mustafa.
Nothing. I was just mentioning, like, I think most of them here in US now doing neoadjuvant, and there's one clinical trial because I had one patient before, like during my rotation, like she didn't get neoadjuvant chemo radiation, and she was not eligible for vaccine trial. They have now a vaccine trial instead of immunotherapy as like post surgery or post radiation. So this one was interesting. That's all. They have no vaccine trials, what I want to say, but you have to get neoadjuvant chemoradiation first.
Yes, they have been studying tumor vaccines for a while, but no breakthrough has been made.
No, this one I think they had a good results for
I
this
think in
one.
melanoma it has like some positive data about tumor vaccines. So
Yeah, they are using it in this setting, like when patient has like stage 1 or 2, stage 2 resectable, and they give it just for surveillance. I think they have a good results for this one. Yeah.
Okay, that's good. So if you have like pembrolizumab and atezolizumab and nivolumab and durvalumab, all these agents available in the pharmacy. So how do you choose between them for your patients?
The neoadjuvant setting?
Yeah, in the perioperative setting. Because we don't have like direct comparison between all these
usually Nivo with chemo is given in the neoadjuvant setting. In the perioperative setting, you can give as you mentioned, you can give chemo and you can give immunotherapy in the adjuvant setting. يعني other Bembro or Atezo in the adjuvant setting, while in the new adjuvant setting, most of the studies and they recommend Nivo with chemo rather than Bembro and or Atezo.
Yes, yes. But if you have like all these agents and you can go for each any of these approaches, is there like one Nivo is like better than Bembro or
I think
you
Nivo
don't know?
is a standard. I think Nivo is the best choice.
Yeah, I
Okay.
mean, yeah, I would follow also the clinical trial. So there's, with the Nivo, of course, there's a study for it. There's Pembro, there's another study. So if you're giving, the patient, protocol treatment, I would continue to, to use that. So I agree, like Nivo, but there are also some studies with the Pembro that were positive. So I'd just follow, the protocol treatment.
Okay. Okay, Noreen, next, please. So this is just like a summary. This part is like when we are studying for PhD MD is a nightmare because there is like hundreds of trials and lots of results. So yes, next to Noreen, please.
Okay, thank you, doctors. To sum up, to our patient, MDT discussion recommended new adjuvant treatment. Patient received 3 cycles of gemcitabine plus cisplatin, and CT chest evaluation show mild regression for both lung mass and mediastinal lymph node. However, MRI brain show a focal patch of infratal cortical and subcortical region measured 21 by 19 millimeter. Query a post-chemotherapy local encephalopathy. And indeed, our patient underwent upper
Voice.
so the final pathology AMX stage 3A. And now, for this discussion with our dear doctor, what would you give as the adjuvant treatment for this case, considering the patient developed CNS toxicity and the duration of the treatment?
طيب. One comment before discussing this question. يعني why did you choose GEM and CIS, not Bimetrixid CIS?
Yes, according to NCCN guidelines, GEM is for squamous cell carcinoma mostly, and this
Yes,
patient is non-squamous, yes.
yes.
I think because we have a shortage of carboplatin at our center at this time, so we shifted patient to gemcitabine.
A shortage of pemetrexid, probably, right?
Bimetrixid.
Yeah.
Adenocarcinoma, right?
Yeah, adenocarcinoma. Usually we go for Bimetrixid rather than gemcitabine if it is an adenocarcinoma.
Yes.
Right. But
With
if they,
cisplatin or carboplatin, whatever. يعني it
yeah,
doesn't, but mainly with cisplatin. Yes, it's okay.
right.
يعني
But if,
cisplatin Bimetrixid rather than cisplatin gemcitabine. Okay.
right. But it looks like they had shortage of pemetrexid, so
Yes.
it's a platinum doublet, so
Yes.
should be okay.
Okay.
The problem now is I don't understand what was the CNS toxicity. Is it like attributed to
They
like
attributed to mostly to cisplatin, but يعني it's short term, very short term, يعني very abrupt onset.
encephalopathy? Was the
يعني
patient
focal patch of abnormal high signal on TTW1 flare image in the right frontal cortical and subcortical region measuring 21 by 19 millimeter with no restricted diffusion pattern or post contrast enhancement. Query post chemotherapy leukoencephalopathy.
is the patient symptomatic from that leukoencephalopathy?
No, it's just a complaint of headache.
Is the patient having metastatic disease or also or something or just this finding?
No, just this finding.
It's a radiological finding. يعني they are doing the MRI brain as a routine part of the metastatic workup, and incidental finding it was this leukoencephalopathy.
And okay, patient not symptomatic. Okay, that's fine. So now we want to get adjuvant therapy. Of course, it's indicated. The lymph nodes, unfortunately, were positive as well, but the margins were negative, right?
Yes.
Yes.
Yeah, yeah, I agree. Okay, so yes, do you like, is it available all treatments or what was the discussion?
No IO,
Tell me.
no immunotherapy available, unfortunately.
Okay. Okay, so we need adjuvant therapy. Immunotherapy is not available. We might need radiation. Sometimes I have problem with the radiation because right after surgery, right away, patients are too sick to tolerate like chemoradiation. What's the performance status of the patient at this point?
PS1.
Wow. Okay, so good performance status. And we got 3 cycles of cis gemcitabine. Is pemetrexed now available?
Yes, yes, we got.
Um, it's a little bit tricky. Can you go to the slide before this? Sorry, once more second. So we have a subcarinal. Yeah, اللي هي, yeah, the one before.
The
Yes.
histopathology,
We
yes.
have
Oncology.
we have subcarinal, we have T2NA. Yeah, so unfortunately, we'll need to continue some more adjuvant, unfortunately. And at least if you want to give him a couple more cycles of platinum based, he might not have done the best with the gemcitabine. Can we do maybe a couple cycles of cis alimta and see, or carbo alimta at least, and see how things go like?
Yes, sure.
Again,
That's
again, we
good.
must,
I mean, the other
again,
option to do radiation as well because of the lymph node, but I just get scared because of the toxicity and how the tolerance is. I'm wondering what others would say, but I would at least give a couple more cycles of if you want to change the gemcitabine based to alimta based.
Dr.
And the
Manar,
radiation is sequential, not concurrent?
No, you can do radiation with that. I mean, basically, the data is more with the taxane, like, cis taxane or carbotaxol with the radiation weekly.
yeah, at this point, Dr. Manar, يعني once we have a histopathology specimen, I think this is the time, if not before, to do the
Molecular.
EGFR and ALK and BDL. If you don't have immunotherapy, we have other targets
Mm.
in the
Yes,
adjuvant
yes.
setting. يعني
Yes.
anti EGFR or anti ALK can be given in the adjuvant setting, but we have to decide based on the molecular profiling of the case. يعني if we didn't do it before on the preoperative biopsy, I think we should do it now.
Yes, yes, it's negative. He is wild EG4 and wild also ALK negative and ROS1 negative.
Okay, so I agree with Dr. Salah so much about the molecular profiling. If you did the molecular profiling before the surgery and it was all negative, I would still rerun the test in the specimen now done because it's a larger specimen after the surgery. Because believe it or not, I find surprises. Sometimes with the biopsy, I don't see any mutations, but on a larger, scale tissue or liquid as well, I find mutations that I might not have found before.
Wow, this is really interesting.
Yes.
Yeah, we published about biopsies, serial biopsy or liquid biopsy as well, because sometimes even if you check a piece of tissue, it's heterogeneous. So I would check definitely liquid and recheck the biopsy, the tissue after the surgery. Absolutely. And if patient cannot tolerate more chemo, I mean, basically because of course, for all our studies, we do like couple of like we do chemo then followed by targeted therapy. But if the patient sometimes cannot tolerate more chemo, we can do the targeted therapy, of course. But for the immunotherapy, is it absolutely not present, or it's just the cost, or what is the status?
Well, it depends on the like the insurance covering for the patient. If he has like strong insurance, he might cover for it. But most of the patients like have something like Medicaid in USA, which is like carries a bare minimum.
Governmental support. Governmental support
Yeah,
usually does not cover the cost of immunotherapy,
not
but it
yet,
can,
but hopefully in the near future
yes.
we might have
But
some.
insurance or the patient own cost, he can afford the immunotherapy.
Okay.
طيب. Again, for the radiation therapy, as Dr. Nagla mentioned, yeah, usually the radiation therapy, if the patient was given pre-operative or neoadjuvant chemotherapy, and we did a complete resection of the tumor, even with subcarinal lymph node positives, usually we do not give post-operative radiotherapy unless there is positive margin or positive residual. or يعني high risk factors in the lymph node يعني capsular invasion or whatever that will raise the staging. The patient was staged as N2A based on this subcarinal lymph node involvement. يعني radiotherapy here is questionable actually, but I think يعني the patient is a candidate for adjuvant systemic therapy. If not immunotherapy, again, as Dr. Nagla mentioned, we can يعني complete 6 cycles of chemotherapy or whatever. Dr. Manar, you have any addition?
Uh, mm, yes, I totally agree. There is like an ongoing debate about the role of radiotherapy in resectable N2 disease.
Yes.
Yes. So Noreen, do you have further questions?
Yes, the last one. What's your proposed plan for surveillance in this patient, Dr. Manar?
Yes, because we have like conflicting data. Some trials say that like there is no difference if we would do like careful and strict surveillance doing a bronchoscopy and CTs and PET CTs as follow-up for the patient, even if they are asymptomatic, versus just regular follow-up every 3 to 6 months with clinical examination and asking for radiology if there is symptoms. So I was wondering, what do you do as your practice and in the daily clinic? How do you follow up those patients?
So I want to bring up a point. I myself learned it the hard way, because if you got the patient now after surgery, be careful that the next scan you will do. Basically, of course, I prefer, of course, PET CT, because you will want to follow the rest. But sometimes PET CT also is very expensive, and even in the US, sometimes insurance wouldn't approve it. So I would do CT scans, and I do it 3 months after surgery, or if you're doing radiation in some situations, you want to do after 3 months, not before that, because post-operative changes can cause confusion in the interpretation of the images, because they will show like inflammatory changes or post-operative changes. We think it's recurrence, and we don't want to expose the patient for treatment that's unnecessary, whether it's unnecessary radiation or chemo, if it's just post-operative or post-radiation changes. So I would do definitely this patient needs systemic treatment. If you want to do like carbo or like cis pemetrexate for 2 or 3 additional like cycles. Basically, you want to really finish up 4 to 6 total cycles. You got 3 cycles before, you want to do like 2 or 3 more after. I would try to see if the patient can get immunotherapy for the 1 year,
Yes.
because that's the standard of care. Then after that, make sure that we do the surveillance every 3 months for like the couple of years. Then every 6 months afterwards. I just follow the guidelines, not anything else.
Okay.
And
And
make
doc-
sure to do MRI for the brain
Yes.
every 3 months also, because
يعني
sometimes if you find like a small lesion, you can SRS in the brain rather than wait until, I mean, if it's like a lot of metastasis.
Yeah, we don't want him to be symptomatic.
Yeah, Dr. Manar, يعني the surveillance in cases treated cases of lung cancer يعني compromised to يعني consists of two issues. One issue regarding the lung itself, and the one issue for second malignancy. As we know that smoking is a risk factor for other malignancies as well. So surveillance يعني surveillance in one hand as Dr. Nagla mentioned regarding the lung cancer for progressive disease, for recurrence, for second primary in the lung, for metastasis, and surveillance for second malignancies in other sites. As we all know that the patient is يعني chronic obstructive pulmonary disease, long-standing history of smoking. So we have to surveillance the patient survey the patient for other malignancies in addition to the lung cancer itself. Yeah, lung cancer, we are concerned about disease recurrence or progression or metastasis. So we go with the CT scan with contrast, as Dr. Nagla mentioned, 3 monthly in the first 2 years or so, and then 6 monthly or yearly till 5 years or so. But meanwhile, we should be vigilant about second malignancies in other sites induced by smoking.
Yes, Dr. Salah, and you raised an important point about the smoking. It's very difficult to convince our patients to stop smoking, especially when they already have developed cancer. It's
Yes.
like there is no way you can convince them to stop. So, and knowing that we don't have like smoking cessation clinics, and we know that the efficacy of treatment is compromised with this
Yes.
continuous smoking. It just puts us in a terrible situation.
Yes.
I think it's very important actually to press the point of smoking cessation. I would tell you that yes, it is difficult. Sometimes my patients, I'm like, okay, I'm scared to go further because they'll be like, we want to smoke. Sometimes I sort of like mention other tricks. Yani, how much do you spend on a pack of cigarettes a day? It's expensive still, right? So if you want to put even like those few dollars every day in a box, and then at the end of the year, just take whatever amount of money this is and, do something with it. Sometimes I try to convince them in other non-medical ways. Sometimes it works. And then also, those patients are also in need of, smoking cessation programs with like nicotine replacement patches, therapies, counseling, psychology, because it's an addiction. So, I don't know if we can basically have some sort of like, support in something like this. I think this is worth the investment, because if you can decrease the risk, if we already have pollution, air pollution and other non-cigarette pollution. The other thing also that I want to raise is also, the non-conventional smoking, the shisha,
Yes.
الباسيف smoking الحاجات دي, like 1 hour of shisha equals 100 cigarettes. So we also want to make sure that we raise the awareness in this regards.
Yeah, our patient believe that is a healthier option. Shisha is like
Yeah, especially that when you're sitting, actually you expose others, and it's an indoor, unfortunately. Like, unfortunately, even in the US, actually, in the Western population, they started also doing the shisha and hookah. I don't know. I was like, that's not a good habit to get يعني, our youth in. But yeah, unfortunately, it's not accounted for in the lung cancer screening programs.
I think now one of the initiatives made by the government regarding the screening and early detection involved the screening and early detection of lung cancer I think they can incorporate now some sort of smoking cessation program for the screened cases rather than the diagnosed cases before diagnosis. I think this will eliminate a large portion of the diagnosed cases of lung cancer later on, but it will take time, of course.
Yes, we hope this happens in the near future.
Okay.
Okay, Noreen, would you like to
Yeah.
add anything, Noreen?
No, thank you.
Thank you for your excellent presentation.
Thank you so much for you, doctor.
Thank you. Okay.
Yeah. Okay. Thank you, everyone.
Thank you. Nice meeting you, Dr. Nagla.
Yeah, nice meeting you too. Thank you
Okay,
so
my
much.
dear.
Yeah.
يعني hoping to see you soon in Mansoura, inshallah.
Inshallah, I will be in Egypt on the traveling 20th of January. I'll be there for like 6-7 days.
Okay. Will you by any chance visit Mansoura or Cairo?
مش في
مش في البلان؟
كايرو مش في بس I don't know. We'll see.
I think the oncology center will be pleased to host you and to
Sure.
accommodate you for 1 day or so.
Yeah, sure.
Yeah,
Let
that
me
would be
know.
great.
Yeah,
Okay,
I'd
my
love
dear.
to just let me know the availability and we'll look forward to it.
Yeah, I will
Inshallah.
connect Dr. Manaro with Dr. Nagla.
Sure.
Yeah, that
Okay.
would be great. Okay, thank you.
Okay,
Thank
my
you so
dear.
much.
Okay. Thank you, everyone.
Thank you.
See you next
See you
time.
next
Thank you.
week.
Inshallah.
Thank you so much.
Bye-bye.
Bye.